Gonna go live. Hey, hey. How's everyone doing? It's Hoang here, your girl from Hand Therapy Secrets. Um, let me shift my camera a little bit. What is going on? What's going well? Apparently, I was shifting this around, but hey, hello, hello, hello. Nice to see some people joining. Thank you so much. Are you guys ready to dive into some nerves today? I'm going to spend majority of the time talking about nerve anatomy as it pertains to nerve compression. So if you're watching right now live, hit live for me. And if you are watching this on replay, hit replay. All right. So how's everyone doing? Some of these names, I can't tell who's actually like people's names. But you can always type into the comment, let me know your name, that you're here. And I'm excited to spend a little bit of time with you this Saturday. I was actually on some discovery calls with either people who are looking interested, who's interested in joining the hand exam prep, or just like some of my students. And if they're not successful, we go over and we do like a score audit. So yeah. So welcome. Thank you so much for joining. So hello. Type your name because I see Winlight and I see Rehabby, and I don't know people's names. Give me some names. My name is Hoang. You can say it like W-O-N-G, like Wong. Like you're going the wrong way, but I will help right you. It's always a good common joke. People in Miami know me as Juanita, so there's a funny story with that. But Miami, a lot of people were calling me Juan, and they're like, "But aren't you supposed to be a boy?" And I was like, "No, not really." So, so yeah, we're gonna dive into some nerves today. And if you have any questions, by all means, type it into the chat. Let me know some of your questions. I know that people wanted to like get like a ton of information, but I've got a limited amount of time. And when it comes to nerves and it comes to hand therapy, there's just a lot of information, right? But I think that even though there's a lot of information, we can like chunk the information up in a way that's just easy, it's doable, and it's fun. That's really one of my biggest like things that I value. Just like I want to have a good time while I'm doing it. I want to wait until later to have a good time. And I think that there's ways that we can make, we can make learning easy. We can make learning fun. So if you have any questions along the way, just definitely type it in the chat. Would love to answer some of them for you. Kind of like some things to think about when it comes to, what do you really need to know? What do you really need to know? And I have this conversation a lot with people. But yeah, I was doing I was asking you guys what you wanted. What do you wanted to, when it comes to studying for the exam, what do you really want? What do you really need, right? There's like a lot. There's a good amount of information. So I kind of break it up into like, do you want strategies or do you want topic? Do you want to like learn some like good chunk of information? And it was so close. Like somebody voted the last minute. I did not vote. I did not vote because if I voted, it would have been strategy. You see, could have shared some strategy stuff with you because I think that there's a place for it. Because if you start studying, you're like, I just need to study a lot of information. She was on a call with somebody today, and she's like, I just need to study a lot of information. I said, yeah, but do you really need to study for like long hours upon hours and hours and hours of just information? Because that's what people generally do. They just try to read the book from like start to finish. They try to watch a lot of YouTube videos. But sometimes that the information is like way beyond what you need, right? Way beyond what you need. And then you're not able to dial it into the actual things that we as a certified hand therapist need to know. We need to be the critical thinkers, problem solvers, and decision makers. Now, I say that a lot because it's true. It's true. And I'm going to give you an example of a story as we go through anatomy, right? Um, we are the decision makers when patients come to us. They come to us whether they have a prescription. Now, you might be used to working with people who come to you only with prescriptions, but even those people with prescriptions, you still need to evaluate them in a way that catches problems, anticipates issues. And on the exam, that's part of what you have to be able to do in order to pick the best answer and to pass, right? So regardless of whether you're the decision maker when patients are coming in, you're deciding what you need to do, where you need to work on them, how are you going to do it, you are the decision maker. And then you're still the decision maker when you take the exam, right? So yeah, so that's something to really consider as you study. There's some people I talk to, they're a little bit early in their career. I was just talking to someone today, and she just started this. OT's her second career, like OT's her second career, and so she just got started, and she finally got the job in hand therapy, and now she's in the hand therapy mentorship program. But she wanted to get on a call with me because she's like, but I need to learn so fast. I need all this information right now. And it's a reminder, make it fun, let's make it doable. And we don't, you can't rush the process. That's like me saying, I need to lose 20 pounds and I'm gonna eat a salad and I'm be like, why am I not skinny yet? Right? So the hand therapy is the same way. There's a process to it, and you want to make that process of what you need to do and what you learn, doable and fun, so you're not completely overwhelmed. People who are completely overwhelmed tend to give up, and I don't want you to give up. People who are overwhelmed, can't see beyond the borders of a box, and so that can be really that could make it really hard and challenging. Like everything's so difficult, and just doesn't make it fun, doesn't make it like you can't see that it's doable, right? So I actually ended up telling her like the hand exam prep program isn't right for you because you're still 2 years before you can even take the exam. So if you are right, if you are studying, if you are someone who just getting into hand therapy, you are just getting that job, developing your skills, don't worry about preparing for the exam, right? Don't worry about it. Like I've got people talk about age all the time. That's a whole nother thing. But people are like, I'm in this rush. I gotta take it like, at the 3-year mark when I'm allowed. I think it's a great goal. Like I personally, I had that goal when I was, starting out. It was like 5 years was the test, and I was like, like I want to work towards that deadline. But it's not the end all be all. So if you're new to hand therapy, if you're wanting to learn some anatomy so that you could better treat the people in your life, the patients that come to you, you know take what I'm going to give you today and see how you can apply it, right? Now, if you are someone with more years of experience, like you've been working for a while, and it really doesn't matter. It doesn't matter how many years you've been working. If you're ready to sit for the exam, then take this information and then you have to like in a way dial it up a little bit, right? So I'm going to just teach you where you take the information and you dial it up a little bit, because when it comes to the exam, you do need to know more specifics. You have to have more specifics along with you have to have the ability to think more specifically, but also to think back to like what would just need to do in terms of treatment, right? So it's not all about the brachial plexus. Everyone wants to talk about the stupid brachial plexus, but I swear to God, it's not all about the brachial plexus. Because let me tell you, if you memorize the brachial plexus, but then you don't know what to do with that information, it's going to kill you on the exam. It's going to just really kill you on the exam, right? So right now, the hand exam prep program is open for enrollment. We start our first calls on Thursday. No, not Thursday, on Tuesday, February 2nd. So I'm actually doing some discovery calls with people, want to see what kind of they want to see what kind of help we provide and that kind of stuff. So I'll provide it somewhere along the way, like a link to book your discovery call, right? So anyone here have specific questions on a particular nerve injury case that you have or anything like that? Hey Marlene, you can actually message me or I'll message you about the details of the program. I don't want to take up everyone's time to talk about the details of the program because everyone's in a different place, and I just want to make sure that the live stream that I provide is like really useful today. So I just wanted to let you know, like, if you like how to consume what I'm putting out today. So, so if you're just starting out, like, just enjoy, see how you can apply it to your patients. And if you're studying for the exam today, see how you can use this information and like dial it up a little bit and how you would apply it, as a decision maker of what you would need to do and what else you need to know and study for the exam. All right. So, when it comes to nerve compressions, right? When it comes to nerve compressions, I find it when I was first starting out and when I was first studying this, I found it really, really challenging because as certified hand therapists, we're kind of known for like these post-surgical cases, like doing things that are post-surgical and complex and stuff like that. Now, as someone who's been practicing for over 20 years, those complex cases, they're easy in the sense that you already know what happened. You know exactly what happened. If you see a cut, the story tells you they fractured something, they crushed something, they cut something. You already know where that issue is. So you don't have to figure it out. You have to figure out what to do at that moment and how to progress them, what you're allowed to do, and like anticipate the problems, right? Um, and okay, so all right, and Andres, I'm gonna scroll back to the questions. When it comes to nerve compression injuries, one of the things with nerve compression injuries is that you, as the decision maker, you need to critically think through and say, okay, which nerve is it? Which nerve is it? Where is it stuck? And then what do I need to do as a specialist to help resolve their problem, right? You can't, when they're coming to you, you want to be able to fix them just like they want you to be able to fix them. Like, so in the arm, there's three main nerves, right? There's three main nerves. We have the radial, we have the median, and we have the ulnar nerve, right? So we have three main nerves, and I want you to think about exactly where those problems essentially could lie, right? So if the nerves come out of your neck, come down through your collarbone, right? Down through your shoulder, and then past your elbow into your wrist and into your hand, I want you to think about where the nerves run superficially, right? So the compression can always be at the neck and potentially always be at the shoulder. And then for the radial nerve, that nerve wraps around the humerus, right? That nerve essentially wraps around the humerus, and then it runs. Where's there that spot? There's a spot right here at the elbow. So here's your lateral epicondylitis, and right about so many fingers down, you'll have a compression spot of the radial nerve. The other spot of the radial nerve is essentially down here on the radial side of the hand, which is the superficial branch of the radial nerve. So when it comes to the radial nerve, you're thinking, the location is at the elbow, right? The location is at the elbow, or it could be really at the wrist or thumb area, right? So because you know the anatomy of that, and also when it comes to radial nerves, just think about and when this is more important for someone who's studying for the exam, right? But if you look at, you want to look at like all the nerve distributions, and you want to study in the order in which it innervates the muscles, because that's going to give you an idea of what to look for when it comes to nerve. So outside of the motor branches, right, that go to the muscles that give it function, give it movement, there are sensory branches of the radial nerve, right? And so usually the sensory branch of this nerve causes pain, usually causes pain versus like muscle atrophy, right? So it's really important to understand the symptomology behind like what happens if you have a compression. So they have a compression here, it's going to mimic and it's going to cause pain. It's going to mimic and it's going to be very similar to lateral epicondylitis. And so your job is to be able to rule in and rule out, is it a lateral epicondylitis or is it really a radial nerve entrapment, a compression type of injury? Then outside of the elbow, it's going to run down to the wrist. And it gets a little complicated, but do you really need to know all of like, well, it runs this way and it runs that way? Not necessarily, right? So not necessarily. But you want to think about where it gets trapped, right? Trapped around that scaphoid area, right around that radial side of the wrist. And this branch also is very sensory. So if you have somebody who comes to you and it's like, oh, there's I have like this numbness feeling, I have this numbness sensation or whatever, then that might also be a radial nerve type of compression. Anything as it pertains to numbness to the back of the hand, that's really going to be your radial nerve distribution. So take a look at take a look at the radial nerve distribution of the sensory, and you'll see where it lies. And it goes all the way down to the radial side in the back of the hand here, right? So the back of the hand comes all the way essentially to, I believe, to the PIP, right? So all this, if your patients are like out of the camera, all this sensation back here, your patients are usually going to complain of numbness and of pain, right? So essentially understanding where that lies and the complaints that they're going to have is going to indicate to you, okay, I'm going to do this type of testing or this type of treatment to rule in and rule out that this really is a radial nerve, versus just saying, oh, yeah, the prescription said it was Decker vein, so I'm going to treat it as Decker veins, right? I had a guy who came into me, bilateral thumb pain, and he would tell me it had been going on for 3 or 4 years. He had gone to therapy like elsewhere for like many times. Like I forget how many times he's gone. He's worn braces, he's worn wrist support splints. They didn't help him because it's not stopping the the thumb part. So he would then move his thumb a lot and it would cause him more pain. So he ended up switching to thumb spica splints, because everywhere he was going, they were telling him he had Decker veins. And after he had like a couple of injections, all this treatment, it had gone away for a short period of time. But every single time he starts working, he works too much of the computer, he's typing a lot, like he would have such pain going up and down his arm, and he could not like stand to move, right? And he would wear the splint, it would feel good for a little bit, but then it would get worse, it would hurt worse. By the time he came to me, he hadn't had it for a while, but then it started to flare up. It started to flare up, and it's like everything you're doing is all towards Decker veins, the splinting, the ultrasound, the whatever, and none of that was working. And sometimes these key indicators, those stories that our patients tell us, really can point to, ruling out and ruling in what else. So he tested, he didn't have Decker veins, he didn't have that palpation pain, none of his stories were working. And then so we decided to, go a little bit easier. We decided to do some not splinting, some kinesiotaping and very specific movements. And I sometimes, if people have had it for a really long time, I'll start working a little bit more proximal and then going down to distal versus starting from distal and going up to proximal depending on the situation. Well, he actually didn't keep coming, but one of the things that he kept doing was he kept overstretching. He'd be like, "But I stretch like this," and then it would feel really good, and then it would come back. That is also an indicator. And I told him, I was like, your nerves are so irritated, you're most likely stretching it. So, if you think about that nerve and where it runs from an anatomical standpoint, people have a tendency to stretch and stretch like this for those wrist extensors, thinking that it can actually help them. But if you overstretch them and it's a nerve problem, you can see where that anatomy goes and it's going to overstretch that nerve and kind of irritate it some more, right? So know exactly where that is and kind of understand some of the symptoms that your patients are telling you. That's going to help indicate to you where, where the problem is, in terms of location, but also which nerve it is. Most likely, a lot of people now come and tell me I have carpal tunnel, just because carpal tunnel is a very popular diagnosis and most people know it, right? But that doesn't necessarily mean they have carpal tunnel. So it's up to you as a specialist to understand, okay, well, if you're telling me numbness here and pain or numbness here, let me rule in and rule out some of these other problems so we can treat it the right way. We can actually solve your problems, right? So that's essentially radial nerve types of compressions and where they could be located right here at the wrist and right here. I always do rule out some shoulder stuff because when we get to the median nerve, the most common area that you're going to see is here at that wrist level, right? Or here at the neck. Now, it comes out from the neck, runs down the arm, and it goes through that elbow. Right? It goes through that elbow, comes down, and runs right here in the median nerve. Right here in that carpal tunnel area. Now, the reason why it's really important to know your location, especially with that median nerve, is every single time you have a post-surgical case, right? Any kind of post-surgical case, you run the risk of possibly compressing onto that nerve. We see it a lot with distal radiuses, any kind of wrist types of injuries. I've also seen it with biceps or bicep tendon ruptures, and they need surgery. We've seen the compressions as well. Usually they'll release down here, but when it comes to the median nerve, that's the most popular. And these are the nerves that are going to go to this finger, this one, and then half of this one. And it's very much a sensory nerve. So there's a certain branch that comes off um, distal to the elbow that you're going to see that sensory branch coming to those fingers, right? The motor part is, especially in the median nerve, as it runs down the arm, you're going to see that it goes towards some of the wrist flexors and of course the finger flexors, right? So if you have a compression somewhere at the wrist, at the elbow, at the hand, that's where you're looking for the atrophy. You're looking for those wrist extensor, the wrist flexors, because they will start to atrophy. And the nerve there also goes to a lot of thenar muscles. So one place I look is for thenar atrophy as well. So if you're studying for the exam, it's going to be really important for you to know the order of the innervation of that median nerve, right? And you want to memorize in the order of innervation, and then you want to know, like, because that's also one of the things that you're looking for in treatment. If you're in treatment, the great thing is if you're in treatment, you can look at a book, right? You can look at a book, a review, and say, oh, okay, the median nerve goes to the wrist, the wrist flexors, the finger flexors, works its way down, and once it goes in here, then it's going to go to my intrinsics, right? Um, and so that's essentially the nerve anatomy that you're considering when it comes to that. If you're treating, like, at no point do you really need to focus on trying to memorize all of the nerves that the median nerve innervates, right? All the muscles that the median nerve innervate in the order in which it innervates it. If you're treating, your most important thing is to say, okay, what's the testing that I need to do? How do I make sure that, if it's negative here, if I'm doing a phalanx and it's negative, but they still have the sensation, like, how do I test all the way up? Right? How do I test and rule out neck stuff? How do I take a look at the shoulder? The key thing with the shoulder is a lot of times these patients come to you and they look like they have great motion, but it's usually in the detail to see like where is their scapula really sitting? Is it sitting where it's positioned like this? Is it sitting where it's positioned a little bit more abducted? And I might take a look at their posturing. I might take a look at their neck, right? I might ask questions like, do you have any, history of neck problems? Do you have any blah, 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 right? So there's a lot to it to be able to then rule in and rule out neck issues. Now, when it comes to the ulnar nerve runs through the same thing. It might be a shoulder problem. And the funny thing about the ulnar nerve as it crosses through is, I don't know if you've noticed, but I notice this a lot when I'm doing if someone comes in and has like nerve issues and I'm doing anything overhead, sometimes overhead movements can cause more numbness. So that sometimes if you go and you move them, and one of the tests, I think, to rule in and rule out like thoracic outlet syndrome, like where it's just at the shoulder, is the Roos test, where you're having them to move their shoulders, hold it in position, and then move their fingers, right? So that's a really common one. But sometimes you don't even have to do very specific named tests. Maybe just dive into a little bit about like you look at their position, you look at them from front. I always like to look at people from the side. Like, so they're sitting there, I'll look at them from the side because sometimes their body is actually somewhat rotated, like, so one side's going to be a little bit more up and the other one's going to be a little bit more back. One way I look at that is also in supine or in prone, and I'll stand at the head of the mat and I'll just take a look down and see, okay, well, where's that positioning? Sort of messing them up in the shoulder. But anyway, I digress. Uh, so when it comes to the ulnar nerve, you're looking more at, so it could be at the shoulder. The most common spot where it's going to get trapped, obviously, is in that cubital tunnel space. And so what is, you always want to think, what is there where these nerve gets entrapped, right? So for example, what is here where the radial nerve gets entrapped? It's actually a bunch of wrist extensor muscles, right? What is over here where the radial nerve, the superficial branch, gets entrapped? You've got tendons, you've got extensor tendons, thumb extensor tendons, index finger extensors. You have a lot of wrist muscles. So you have your CMC, so that's your first metacarpal, and then right down below you have your trapezium, your scapula, all of these radial sided carpal bones, and that's where, even if you didn't know exactly what everything is, that will help you, using anatomy, help you to dial into like, what should I be moving, stretching, moving, or even like, the area that I should be treating, right? When you think about carpal tunnel, think about, okay, so the carpal tunnel is really well known. So you know that there's tendons that pass right through. It's the superficialis and the profundus. What else is there? So that's in the same bundle. But then what is around that area that really kind of irritates or can irritate it? Well, you have your thenar muscles, you have your hypothenar muscles. Maybe all that's tight. You have your intrinsics. Maybe all that is really tight. That could really put pressure and compression to this area. So then think about, your ulnar nerve and its location. It's the most superficial, but what else is around here? You have your medial epicondyle, and then just think about if your medial epicondyle is there, what are some of the muscles that are attached, that originate there that can also play a role in how it's compressing that ulnar nerve area, right? So you have your wrist flexors, that are all like the ulnaris ones, like the extensor carpi ulnaris, the flexor carpi ulnaris, like all the ulnarises, right? Um, that play a role. You have your supinator no, your well, there are supinator and pronator muscles in there, but could they be bothering? Supination and pronation could be bothering that ulnar nerve? Probably. What else is there? So if you're looking at just anatomy, also what's right here? The triceps. So think about the anatomy, not just of the nerve, right? But also the surrounding tissues that are serving or playing a role in that compression. And it's a really great way to tease out, what's wrong, how you would treat it, what you would do. So when it comes to the ulnar nerve, and you're trying to think of like the muscles that the ulnar nerve innervates, the muscles that the ulnar nerve innervates are actually these two ulnar fingers. They play a role in the innervating the profundus, right? And they also play a role in innervating these ulnar sided muscles, along with the nerve that goes across and innervates the adductor of the thumb. So when it comes to ulnar nerve, besides just, okay, here's testing it, to see if it's compressed. So that nerve runs through the elbow. And so when you bend your elbow, it compresses there, that nerve. And that's a very common spot that, if they are irritated, that's going to be the spot that compresses and irritates. The least common spot is actually here at that ulnar wrist, the Guyon's canal. It's not that common. It's usually where, if there's some kind of fracture or injury to that spot, you might see that is compressed there. And usually, if it's compressed there, wherever it's compressed, it only affects the nerves that are innervated distal to it. So if the compression is up here, you're going to see more muscle atrophy outside the hand. If it's only right here at the wrist, you'll only see it right here, inside the hand. So in terms of nerve anatomy, you want to break down the radial nerve, the median nerve, the ulnar nerve, and essentially where anatomically, surface anatomy, essentially, where it goes, right? And then you want to think about, if you want to chunk the information up in a way that's just easier for you, just think about the main muscles and the symptomology that goes to, right? It just kind of makes it easier for you to understand, easier for you to remember. And then if you're studying for the exam, you take that initial information and then you just stack upon it, just like start to stack upon a little bit more detail, right? Let's see, what else? What else was I going to say about the ulnar nerve? Oh, I was going to say about the neck. What was I going to say about the neck? So if you are testing and you're treating and you're going to her and like, oh, there's nothing wrong, there's no joint stiffness. Most of the time, they're not joint stiffness, right? There's no atrophy, but they just feel a lot of numbness thing. Like, everything is telling you, I don't really think it's right there. Then it is most probable that it's from a more proximal site, right? So first, I'll look at the shoulder and I'll just check. All right, since all those nerves, the brachial plexus, all those nerves that break down right there go through the shoulder. You really want to look at the alignment of the shoulder. It's so important to look at that alignment of the shoulder, how it moves. Actually, sometimes people who come to you with nerve injuries might be more hypermobile, that is also a thing that you want to really think about. If they're really hypermobile, they might be tensioning that nerve too much. The muscles might not be supporting um, and giving you that support that you need in terms of holding everything into place, right? I kind of have that problem because I'm very hypermobile. We have too much motion, so I need my muscles to kind of like tighten up, hold everything together, so I don't literally just like fall apart, right? So when you start thinking about the neck, I want you to dive into dermatomes, right? Think about dermatomes and yes, you do, Jen. Um, so think about dermatomes and think about, and this is going to guide your questions because if you know exactly where those nerves run, if you know exactly where those nerves run, and then you start to test and rule in and rule out stuff, at some point you might rule in and rule out that it's not down more distal. I have a guy who had a nerve laceration, huge laceration, affected all three of his nerves. And as we were treating, we got the shoulder better, we got the elbow better, the wrist is better, the hands better. Obviously, it's a nerve laceration, so there's a certain amount of time that we're waiting and we're keeping everything in check. And we are making sure that everything's moving well. Well, he kept kind of coming in there with the last time he came in, he was like, "Oh, my hand's just feeling really cold," and we had gotten that better, but somehow it had been a couple weeks, and he just wasn't like he started feeling his hands go numb, go cold, and so I pretty much told him I was like. Well, I checked everything. I said, "Oh, what's really been going on?" And we kind of dialed down to the fact he hadn't really moved that much, sitting around a lot for the holidays. And guess what? The slumped in forward head. It was getting really, really tight right here. So that cold numbness kind of sensation led us to look at his cervical movement and his thoracic movement. And then, we, of course, I thought, what dermatomes, right? Dermatomes. So anything neck related can kind of radiate down the arm and give it like some sensory disturbances. So anyway, when it comes to nerve anatomy and nerve compressions, I want you to really think about all three of those nerves. I want you to think about its location to rule in and rule out what might be going on. And then if you move yourself more proximal, then definitely take a look at the shoulder and the neck, right? So that's pretty much like in a nutshell, some of the nerve anatomy, um, like how I would hope that you would start to think about it. Start to think about it, right? So let me take a look at some of these questions. Was that helpful to you? Let me know. Type into the chat. Um, let me know. I think somebody had a question on like what would you do proximately? Like, if you can't find it, again, it really is looking at the nuances and the differences in the shoulder, scapular movement, thoracic movement, cervical movement. And then really so much about it is it's about testing what works and testing what doesn't work. I think sometimes as therapists, as OTs, we're just taught like just do a bunch of stuff, right? I had this talk with my therapist, just do a bunch of stuff. But it's actually in our capacity to be able to test through like what movement works, what movement doesn't work, what activity made you better and what activity made you worse. Because if we can find that out, then we can do the thing that makes you better, not keep picking the things that make you worse. Because we keep picking the things that make you worse, then what usually happens is we get really frustrated and like, why aren't they getting better? Right? And so much of it dives into like you've got to have that fundamental anatomy to know. And one of the reasons why I speak, I think in a way that I do is because I you want to understand the basics first, and then you apply more depth of knowledge. And then once you have that depth of knowledge, you can then, there's a certain amount of mental flexibility to then go back and say, okay, well, if I know that this nerve is innervated like this, and it's goes in this particular order, if I have this type of complex injury, I'm going to know how to apply my knowledge. That's the biggest thing is, when you're studying for the exam, I have it on my mind right now, doing some calls. And when you're studying for the exam, so much about it is about applying the knowledge. It does not help you to sit there and think, oh my God, I have to memorize everything. It's just not doable. It's not feasible. It's not feasible. It's not fun. It's not feasible. It's not fun. All right. So, any questions? Type into the chat. Let me know. Let me know. Let me know what's going on. We have a patient who suffered a fall, had a closed fracture of the proximal radius, was doing well, but now cannot straighten the elbow again, cannot flex, cannot straighten the elbow, cannot flex the index finger and thumb, specifically the profundus. All right, any thoughts? Proximal radius. Can't straighten the elbow. I don't know about the straightening the elbow part. Was he stiff there before? But yeah, if somehow they don't have movement, right? If you can get passive movement, but you can't get active movement, I would definitely look at the nerves. So if we're looking at the nerves, which nerve would it be? Would it be more a radial nerve, a median nerve, or an ulnar nerve? So if you're thinking, okay, there's only 3 nerves, and I have to pick the nerve that like innervates the profundus of the index finger and the profundus of the thumb, and that would be the median nerve. And I wouldn't be surprised it was the median nerve because of the proximal radius fracture. So the proximal radius fracture is right by the elbow, and the median nerve runs right through there, and it runs down through the arm, and the forearm rotates, right? The forearm rotates. So it's really important when you have somebody with fractures and injuries. It is not just a fracture. It's not just the bone in the joint. You need to have full motion, or try to get as much full motion as possible. And it's just through full motion that you're going to move tissue, tendon, ligament, skin, fascia, all that stuff, and it gives you a chance to move. It moves the nerves, right? So if you're not moving all of those things, then there's going to be some compression and scarring. Now, you could be moving, and you might be getting great movement. However, sometimes, due to the injury, there is scar buildup. Scar builds up, and over a certain period of time, it will compress onto that nerve, right? So I had a guy. He had a distal biceps tendon repair. The distal bicep gets repaired into that radius, and he did great. He didn't have any motion deficits, but he was just always really, really tight in his forearm from the day of the surgery. Always just really, really tight. It was like the last thing we could get rid of, right? Forearm tightness and that wrist tightness. His elbow was like great. I'm like, oh yeah, no problem with that forearm tightness, because he was like a muscular guy anyway. So when you think about that nerve running through that elbow, running through that forearm, think about its location and the tissues around it that could be causing some type of nerve disturbance. And then because you're able to say, hey, I think that there's some type of nerve compression there, and it is what's the word? Consistent with a median nerve compression, because it's affecting this muscle and this muscle that runs along the median nerve distribution. Boom, we got a median nerve compression, right? And that leads you, and that helps you to flow into, like, when am I going to treat somebody? How am I going to treat somebody? And then knowing when to essentially say, hey doc, after this type of injury, we've been working on this, and this. Patient still with this particular problem, and then you can take it from there. Ah. Um, any other questions, you guys? Anyone studying for the exam? Um, Alexis, back to your patient with bilateral thumb pain. What was the diagnosis and interventions used? So he came to me with his diagnosis of Decker veins, and everyone else who had diagnosed him with Decker veins. I diagnosed him with radial nerve, like the short branch of the radial nerve compression. So we found one or two treatments that really helped him well. We started with a few treatments at the wrist and thumb area to alleviate the tension, but I also did some gentle, just gliding of the thoracic and of the shoulder, and he did really, really well. It's just that nerves are extremely finicky, right? They're the opposite of joints. Like if you have a bone fracture, like, yeah, let's go at it, like we can be aggressive. Nerves don't play like that. Nerves are like, oh, be gentle with me, don't stretch me too much. The problem is people who come in with nerve injuries, like nerve compression types of injuries, they tend to be chronic. They've learned habits that maybe don't fit with what you're looking to do, right? I've solved tons of nerve injuries. We cannot go ham on these stretches. We cannot move them too much, right? And usually when you're overly aggressive, then they flare up, and usually the flare up is a day or two later. It's never the time that you're doing them. Nerves, I mean, I had this one guy like, oh my god, it feels so good, like do more, and I was like, my gut was telling me no, but he was like, come on, like that feels good. And I, like a dingbat, I was like, okay, let me, like, he's telling me all this stuff, and I said, just keep an eye, and it's like, I think it's like a little too much. And sure enough, it was 2 days later. Oh my god, so much pain. And yeah, so we have to, the no pain, no gain. Like people come to us with this mentality already. So sometimes you just have to be really strong and be like, that doesn't work for your particular problem. These overstretches don't work for nerve issues. They work for, if you fell and you broke something, but they don't work for for these like nerve compression types of injuries, like not always, right? Your lady mentioned that she landed on her shoulder outstretched pretty far. Wasn't sure if there was some plexus injury. Well, when people fall, I always think that there's got to be some problem. There's got to be some problem at the shoulder. Every hand, wrist, elbow person becomes a shoulder person. And that's why, as an occupational therapist, as a hand therapist, like I'm really adamant on OTs learning, treating, and becoming well versed with treating shoulders. I mean, you can't treat a distal radius without at some point getting involved in the shoulder. If you're not taking care of the shoulder, your hand won't get better. Like it just won't. If every wrist patient, regardless of how bad their supination, pronation issues are, develop some kind of shoulder rotation types of problems. Like 90% of the time. Might not be bad, might not be a bad problem. You might be able to fix it in like 2 seconds, but it still is a problem, right? Everyone who stops moving, becomes somewhat of a nerve issue, right? Think about that guy that wanted to like wear splints all the time. First of all, compress that area more, and he stopped moving. And then when he came out of moving, he moved too much. Like there's a certain amount of weakness to it, So it really there's so much about like learning anatomy and then being able to apply it, and that's essentially like, when I teach in the hand exam prep, when I'm trying to help people pass the CHT exam, it's not about memorizing. Like I'm not sitting here, I mean, to a certain extent, I am going over the details, right? I like more time to go over the detail, and everyone's got their notebooks. They taking notes, they drawing, diagrams, stuff like that. But so much about it is then applying what you need to know, what you need to know. Like you know, you just gotta do it, man. Just gotta do it. Sarah, yes, studying for the exam. Excited to be working with you. So yeah. Andreas, we were just testing me. We're just these questions. You already knew the answer. You're just like, I wonder if this woman really knows her shit. Uh, Right. Thank you. I love, that active thinking through is, I think, what most people need versus just sitting here and just trying to memorize some shit. Right. I just want to say, even if you're just thinking about sitting for the exam stages, sign up for Hoang's program. Thank you so much. Facebook user, I don't know who it is, but love you. I've learned so many different things, especially in the way specific problem solving critical thinking is. Yeah, so the little things, and I think when it comes to exam, I was talking to somebody about this earlier. When it comes to studying for the exam, right, when you get your letters to become a certified hand therapist, does not say that, oh, I've treated every single thing, like I've never treated a toe to thumb transfer, but if I got one, I would know exactly what I need to do. And that just comes from the being able to critically think, problem solve, and say, okay, this is what I would need to start with first, second, third, without necessarily having a quote unquote protocol or having to wait for that surgeon to tell me what to do. Because I would think if that was that kind of surgery, he would want his patient to go to a therapist who knew what to do in that type scenario, right? So when you think about the CHT exam, you think about that exam in general, they are testing your knowledge and they are testing your ability to apply your knowledge to any case that comes your way, whether it's surgical, non-surgical, whether it's hands. It can be the smallest little knuckle, which are some of the most frustrating injuries, right? But understanding why that stupid, DIP keeps falling from a mallet finger is just as important as figuring out why the nerves, are compressed at what level of the cervical spine that then radiates down to the hand, right? And you need to know the details of it, but you also need to know how to treat it in that treatment that allows you to be able to apply it, right? And so when you are studying for the exam, you don't have to have done everything, but you do need to know what to do if you need to do it. And I think one of the most powerful parts about being a part of a group mentorship program or group coaching program, let's call it that, group coaching program, is that if you don't have the experience, you get to borrow mine. And if you don't have the experience, you are in a group of peers that you can use each other's stories to help then connect the dots when you are, in the exam and studying. One of the things that a lot of people reach out from rural areas, right? So I live in a heavy, dense population, tons of OTs, tons of therapy. In my case, we have so many people that that people have their pick, right? In rural areas, you're the one OT, you're the one specialist, and so regardless, it's still so critical, and no matter what area you live in, people are coming to you as the expert. And to become that expert, you really do need to study in a way that helps you to connect the dots and to be able to apply the information that you know. Because if you can't if you know all this stuff but you can't apply it, then you never get to show anyone your expertise, right? So I hope that you guys got a lot of useful information out of this, whether it's just to, learn about a little bit of nerves. I mean, there's a lot to talk about, to do. There's treatments, there's testing, there's problem solving through it. There's, what's if you're studying for or in treatment in treatment, what splints are appropriate, right? There's a lot of things to to think about, but it doesn't have to be difficult, and it doesn't have to be like endless hours of studying. There's ways in which you could break it down, chunk it up, create frameworks, and is essentially what I've done. So how's that? Good? You guys got some great information. I hope that was really useful to you. If you are watching this on repeat or on replay, hit replay. So let me know if you have any questions. Definitely send me a message. If you're interested in the hand exam to help you pass this coming year, then send me a message, and I'm happy to, hop on a call and see if the program's right for you. All right, see if that's really what you need to, take it home, get those 3 letters. All right, guys, I'm gonna go home. I'm gonna enjoy the rest of my Saturday. I hope you enjoy the rest of your Saturday, and I look forward to talking to you soon. Bye. That was me. I was finally granted permission. Oh, thank you, Sabrina. I don't know how this thing works, but great to see you, Beatrice. Who else? Thank you, Alexis. I'm glad that you got some useful information out of it. All right, guys, have a great weekend. I'll talk to you soon. Bye. I'm gonna end